All right. So I'm here today to introduce Dr. Jessica Stumphy. Note the word doctor ahead of her name. Dr. Jessica Stumphy, who is in the Division of Pediatric Gastroenterology, Hepatology, and Nutrition. Dr. Stumphy attended medical school at the University of Iowa and did her pediatric residency at the University of Connecticut, and then came back to Iowa to do pediatric gastroenterology and then came to us. She has a long-standing interest in inflammation in the intestine and the microbiome, and she's going to talk to us today about Clostridium difficile, a very important and expanding problem in healthcare. Jessica?
Good morning. So I have nothing to disclose, and I'm not going to talk about any off-label drugs. So at the end of this talk, I'm hoping that the audience will be able to talk about risk factors for C. difficile and also recognize the indications for when to test for C. difficile. I'm also going to talk a little bit about fecal microbial transplantation. So I'm hoping that you'll be able to identify patients who would be potential candidates for that therapy. So first, I just want to go over an outline of my talk. I'm going to talk a little bit about background and then the pathogenesis of C. difficile. Talk a little bit about infant colonization and then risk factors for C. diff infection. A little bit about prevention and then how to make the diagnosis, and then treatment for the initial episode of C. difficile, and then how treatment changes for patients who have recurrent C. diff. And at the end, I'd like to talk a little bit about fecal microbial transplantation. Okay, so C. diff is a major enteric pathogen. So it's the most common cause in the Western world of nosocomial diarrhea and antibiotic-associated diarrhea. The incidence of C. difficile is increasing in children, and there's a particularly high risk of recurrence following antibiotic therapy. Because of that risk of recurrence, fecal microbial transplant is becoming standard of care for recurrent C. diff infection. So C. difficile is an anaerobic spore-forming toxin-producing bacillus. So the spores that transmit the infection are resilient and last a long time in the environment. They're very common in both the hospital setting and the community as well. So the infection is transmitted by spores and colonizes the large intestine. So the infection is caused by the protein exotoxins. There's two, A and B, and individuals who are susceptible to the exotoxins develop diarrhea after the exotoxin is internalized, and which causes colonocyte injury and intestinal barrier dysfunction. So not all patients who have C. difficile in their colon develop colitis. So for the host microbiome is important in developing the immune system and forming a protective barrier. So if patients are exposed to antibiotics, the resulting dysbiosis is a major risk factor for developing C. difficile infection. Other risk factors that predispose to C. diff would be advanced age, immunodeficiency, and significant underlying disease. How ill individuals come with their C. diff is also affected by the type of strain that they're infected with. Okay, so the most virulent strain that we're aware of right now is the BI NAP1 027 strain. So we first started noticing this strain, or I guess it was identified in the early 2000s when they noticed that there were more severe infections and more issues with recurrence. What makes this strain so difficult is that it produces high levels of toxin, it's really good at producing spores, and it has more antibiotic resistance. The mortality rate of the NAP1 strain is about 3 times that of other strains, and again, it's more associated with recurrence. So So C. diff colitis is very rare in young infants. We think that children under 12 months are, for the most part, unable to become infected with C. diff, although they certainly have C. difficile in their intestinal system. So the small babies appear to be resistant to the effects of the toxin. We know that they definitely have the bacteria in their system. About 30% of infants under 1 month are colonized with C. difficile, and then that gradually drops over the next couple of years, reaching a carrier rate of about 10% between 1 and 2 years, and then after 2 years, their colonization rate resembles that of the adult population, kind of somewhere up to 3%. So people have put a lot of thought into how it is that infants can have this bacteria that causes so much damage in older individuals, and it doesn't seem to bother them at all. So they've contemplated, is it that there's just low bacterial counts in infants? Are they being colonized by a non-toxigenic strain as opposed to one of the toxigenic strains? Is the toxin receptor that's necessary for disease to happen, is that missing? And then is there something going on in terms of their microbiome or the fact that a lot of them are breastfed that's predisposing them to not be infected by C. difficile? So in regards to, is it the amount of bacteria that's present, they've done studies looking at the amount of bacteria, the bacterial load in adults and the bacterial load in infant carriers, and it's really very similar with the amount of bacteria. So it doesn't seem to be that they have a smaller load of bacteria. Looking at the toxigenicity of the strains, infants have non-toxigenic strains, but they also have toxigenic strains as well. Information on the toxigenic strains being present in about 30% of infants comes from kind of pooled data from 9 different studies with a pretty big sample size of 900 babies or so. They've also looked at the toxin titers between adults and infants, and those seem to be the same as well. An interesting thing is that about 50% of infants are positive for antitoxin antibodies at 1 year of age, which shows that they were certainly exposed to toxin, but they didn't develop any symptoms. This is also something that they're looking into in terms of developing vaccines, potentially for C. difficile. Okay, so kind of the absent receptors is where the thought is where they're putting most of their thought in terms of why we're not having infections in babies. They haven't been able to demonstrate this in human studies yet, but they do have animal models that show a similar finding. So for newborn rabbits, they don't have intestinal receptors for toxin A. And then similarly, they're also resistant right after they're born to Shiga toxin. And then around the time that they wean, they develop that receptor and then can develop the disease. In terms of breastfeeding, there certainly are lower rates of colonization in breastfed infants, somewhere between 10 and 20%, versus formula-fed infants that have quite a higher rate of colonization of around 50 to 60%. It's not sure what's causal in this relationship, so it's maybe there's something in the breast milk that's inhibiting C. difficile, or it may be that babies who are breastfed have a more favorable microbiome that's protective towards C. diff infection. Interestingly, colonization rates after a year of age are unaffected by whether or not babies were breastfed or formula fed. So it seems to have some influence when they're younger, and then that is lost as they get older. So in terms of infants, since we know that they're all colonized, or the vast majority of them are colonized, we don't recommend testing for C. difficile under certainly 1 year of age. And then in terms of testing between 1 and 2, they recommend really thinking about whether or not you want to test for C. difficile before doing that. The recommendations are to strongly encourage testing for more common causes of infection, like viral infections, rotavirus, norovirus, before sending a test for C. difficile. So the main risk factor for C. diff is antibiotic exposure. The most common antibiotics are ampicillin, amoxicillin, cephalosporins, Clinda, but all antibiotics have been associated with infection, even Flagyl, which is we've been using for years to treat it. It's not common, but it can cause it as well. The risk, so advanced age is associated with severity of infection. And with advanced age, we're really talking about older individuals. C. diff severity is, a significant issue in the adult population. We certainly can have kids who get very sick as well, but the morbidity is an issue in adult patients. So other risk factors would be inflammatory bowel disease, history of GI surgery, organ transplantation, renal disease, chemotherapy, immune deficiency, and then exposure to an individual who's carrying the bacteria. So looking at all of these risk factors, they're all associated with changes in the microbiome. So that seems to be one of the common factors. There's kind of conflicting data regarding proton pump inhibitor use. I think 5-10 years ago, we were really pushing that proton pump inhibitors were a risk factor for C. diff, and I think there's enough conflicting studies out there at this point that we're not really sure whether or not proton pump inhibitors really do increase the risk of C. diff infection. To prevent C. difficile, antibiotic stewardship is really important. Hand washing is also a big deal, and then kind of contact isolation for patients who have C. diff. I think probiotics are kind of like the PPI therapy, where there's some studies that show that it might be helpful in terms of treating C. difficile or preventing recurrence, and there's other studies that don't show that it seems to do much of anything at all. So currently there's no recommendations for probiotics in care of C. diff. So for diagnostic testing, we really don't do culture. The EIA for stool toxins, is less common now than the C. diff toxin PCR that identifies the toxin genes in fecal samples. I feel like that's what most institutions have transitioned to at this point. It has a higher sensitivity and specificity than the immunoassay did before. There is some concern that it may be too sensitive, and we may be picking up, identifying people as having positive C. diff when they're not actually having symptoms. And then depending on the DNA test that's being performed at the institution, some institutions are identifying different strains, looking for the more virulent strain. Endoscopy is typically not indicated for identifying C. difficile, although for patients, if there's concerns about recurrence or whether or not someone actually has C. difficile, or depending on if there's a concern for inflammatory bowel disease or if something else is going on, it can be helpful to do an endoscopy and look for the pseudomembranous colitis and the summit lesions on the histology. All right, so testing is really only recommended for patients who are having diarrhea, particularly patients who we know are at risk for developing C. diff, so patients who've had recent antibiotic exposure, that really includes the past 6 months, or have had a hospitalization, do they have a clinical presentation that's consistent with C. diff? So someone who has kind of acute onset rather than chronic diarrhea, fevers, feeding intolerance, vomiting, abdominal pain, bloody diarrhea. Those are all things that should raise a suspicion for C. difficile. So Testing's not recommended for patients who are having formed stool. The lab will probably send it back to you anyway. And then if you do manage to get the lab to run it, the recommendation is that we don't treat people who have solid stools either, because that's just not consistent with a C. diff infection. Additionally, post-treatment isn't recommended, so we don't recommend testing for a cure for C. diff. The virus can be shed the toxin can be shed for months afterwards, so the basis of cure is based on clinical symptoms and if they're doing better. Now, if they do develop, diarrhea after the testing, certainly they could be tested again at that time. I think the patients that are a little more complicated are the kids who have kind of mild or chronic diarrhea, and then I think it's important to decide if there's someone who's at risk for C. diff. Because the C. diff certainly can be a chronic infection, so it's definitely possible that someone could have C. diff for a long period of time and not necessarily have gotten diagnosed right away. But we don't want to be testing all of our kids with toddlers' diarrhea either for C. difficile as well. So I think trying to look at the whole picture in terms of what symptoms are they having, how old are they, and deciding what you'll do with the information when you get the test back. So we've been treating C. difficile since, I think, the 70s with Flagyl and vancomycin. The doses are listed below. The really neat thing about C. diff treatment is that there's no antibiotic resistance. We have lots of problems with recurrence, but we absolutely can treat the acute episodes. So the vancomycin and Flagyl they were probably up until recently considered equivalent for mild to moderate disease. I think there's a recent trend to think that vancomycin is probably superior for all types of disease. But in general, if someone has a positive C. diff test and they're reasonably well, you can treat them with Flagyl or vancomycin initially, and either one is fine. Vancomycin has been shown to be more effective for patients with severe disease, and then particularly for the NAP1 virulent strain, Flagyl is less effective for that one. So I think kind of in the overall trend has been since Vanco seems to be a little bit better, it's getting less expensive, and Flagyl has some side effects. We're trending towards more vancomycin use for antibiotics. So Fidoxamicin is a third antibiotic that's available for C. diff treatment. It was approved in 2011 for C. diff. It's a poorly absorbed antibiotic that's specific for gram-positive anaerobes. The cure rate for the first initial infection is around 90% for both Fidoxamicin and vancomycin. So they're the same in terms of curing that first infection. Where Fidoxamicin is a little bit better than vancomycin is that it's better at preventing recurrence. So the risk of recurrence for the first infection with C. diff for Fidoxamicin is about 15% versus 25% for vancomycin. And that 25% is about the same for metronidazole as well. Of note, the NAP1 strain that we struggle to treat, the improved recurrence doesn't follow through with Fidoxamicin. Fidoxamicin costs a lot, and it has some side effects, particularly neutropenia, and can cause some GI bleeding. I've never seen the GI bleeding, but the neutropenia definitely happens. All right, so recurrent infections, I think, are where we get into the most trouble with C. diff. The risk of recurrence after the first infection is about 20%. The likelihood, so after the first relapse and then treating with antibiotics for the second time, the likelihood of a cure is about 60% at that time. And then if patients again relapse after that first relapse, it just goes downhill from there. The potential mechanisms for why C. diff is so difficult to completely cure is persistence of the spores, diminished antibody response, and and simply that the microbiome has become really out of whack. All right, so treatment for recurrent C. diff, after the first episode of recurrence, or the first recurrence, patients are going to get antibiotics again. So they're either going to get another 10-day course of flagellar vancomycin or a prolonged course of vancomycin. And you wouldn't be wrong to do either of these options. If you decided to go straight towards the prolonged course of vancomycin at that point, that would be okay too. I think in general, most people just kind of repeat the 10-day course and see what happens, but either is equally acceptable. Certainly with the first or second course of recurrence, trying Fidoxamicin is also another option. And then after 2 or 3 recurrences, your risk of having continued recurrences is about 80%. So at that point, your likelihood of achieving a cure with antibiotics isn't all that great. So at that point, that's where fecal transplant comes in. So patients with C. diff have intestinal dysbiosis. Their bacterial diversity is significantly decreased, and the composition of their microbiome is also altered. Specifically, they have decreased kind of good bacteria within the firmicutes, and the Bacteroides aren't as common, and kind of taking over that spot as they have an increased amount of pathogenic bacteria, the proteobacteria. So fecal microbial transplantation, or FMT, is a safe and highly effective treatment for recurrent C. diff. I think the Chinese were doing this back in the 4th century, but the first kind of modern fecal transplant was in 58. So what fecal transplant is it's transplantation of the gut microbiome from a healthy donor, in particular his stool, their stool. So donors are screened via questionnaire looking for high-risk behaviors that would indicate risk for contagious diseases, and then there's screening for both blood infection and stool infections. And then the fecal material is collected from the screened donor and kind of in the past was more commonly administered via colonoscopy, although at this point fecal transplantation has come a long way and we have more options. So they've done studies looking at, does it matter if you do the transplant from below in terms of a colonoscopy or doing an NG or an NJ feed, and the outcomes are, there's no statistical difference between those outcomes. And then they've also have looked at doing rectal enemas as well, although those aren't as effective. So after patients have their procedure and have their transplant, then they shouldn't receive any more antibiotics. And if the procedure has worked, they shouldn't need to have any more antibiotics. So patients, the side effects that patients will note after transplant are, some diarrhea, abdominal pain, nausea, vomiting, but it's typically small percentages and limited for just a few days. So this is data from the Dutch study that was published in the journal in 2013. So they were the first ones to do a prospective study of duodenal administration of the fecal transplant. So what this is showing you is over on the left, it's showing the percent cured without relapse. And then down on the bottom, they show their study groups, which is the patients who had one infusion of one transplant, and then there were 16 for there. And then for the next patients, the next column over would be patients who had 2 transplants. So what's recommended if you have your first transplant and have a relapse is to do the transplant again. And then, so they had three groups in this study: patients who received transplant, and then patients who received just vancomycin, and then patients who received vancomycin with a bowel lavage. And you can see that the patients who received transplant did significantly better than the patients who were receiving antibiotics, so much so that the study was essentially closed in the middle, which is why the N values are so slow. Are so small. They were intending to have 40 patients in each arm, but because the patients on antibiotics were recurring, they stopped the study and then offered FMT to the patients who had been on antibiotics before. So this is the same study, and what this is showing is the bacterial diversity. So the first column on the left is showing, the statistical diversity in the donors. And then the patients are in the middle, and you can see that their diversity is significantly diminished compared to the donors who are healthy, theoretically. And then after infusion, the patient's diversity and their microbial population becomes very similar to the donor. So, I think one of our big fecal transplant works really well. The issue with fecal transplant is nobody is terribly excited about getting somebody else's poop. That seems to bother people a little bit. We know that this is a really good treatment, but it's been limited, kind of based on those administration barriers. And some of those are not just kind of the yuck factor that's associated with it, but also the fact that if you're doing a colonoscopy, that means, having to go to sleep, having to do a bowel prep, and then having a colonoscopy, which is invasive and also costs money as well. So people have been very interested in, can they kind of par down this treatment? And so what different institutions have been working on is developing a capsule fecal transplant. And so they're developing freeze-dries encapsulated preparations that people can take by mouth. So our adult colleagues across the river are actually one of the institutions that are working on this. They very recently published a paper describing kind of their work over the last couple years developing this program. So it's not, so much that they did a standardized study, but they had so many patients, I think 49, that they treated with their capsule, which is a lyophilized, freeze-dried capsule, and then monitored their results. They did make some adjustments to the protocol. They started out, I think, by doing like 27 of these capsules given over a couple of days. And then by the end, they decided that probably wasn't necessary. And I think they were running out of stool sample a little bit as well. But at any rate, they were then giving 4 capsules and over one day at one administration. And the results were the same for doing that. So I think they got some good information from that. So of their patients, 88% were successfully treated and didn't have any recurrence over the 2 months that they were observed afterwards. The microbiome studies demonstrated improved diversity, which included the increased amounts of the good bacteria, the firmicutes and the Bacteroides. One patient was hospitalized the following day after the transplant, otherwise for a UTI. There were no serious events during the course of their study. About 1/3 of patients did notice some bowel irregularity, bloating, irritation, and those symptoms lasted for a week or so after they took the transplant. So this is now the standard of care for the adult fecal transplant across the river. They certainly will still offer the colonoscopy or the liquid preparation for individuals who can't swallow or an aspiration risk, but this has worked out really well for them. There was another institution that's doing this is Mass General. They recently published information on like 200 patients that they administered Capsule FMT. There were 5 of them who were under 18, so that was the closest thing I could find to capsules being used in pediatrics. I think it's certainly coming, but there just isn't data in pediatrics yet. So in summary, C. difficile is one of the most common causes of nosocomial infection and antibiotic-associated diarrhea. Colonization is common in children under 2 years old. Antibiotic stewardship is really important for prevention, that and staying out of the hospital. Recurrence is common, and for individuals that have repeat recurrence, fecal transplant is going to be the best treatment for them. I think that's it.
Very nice talk. What regulates the expression of the toxin receptor, and which specific cells express that?
I think it must be on the colonocytes, and the only reason I'm saying that is because the receptor is responsible for bringing the toxin into the colonocyte, and from there it causes the cell to die. In terms of what regulates the receptor, I don't know.
Use of FMT in immunocompromised patients, is it done during periods of immunosuppression as well? Can it be done during those periods of time? Does it have to be repeated? We have a lot of kids, teenagers especially, who develop C. diff, but they may be undergoing a year of treatment for something. They relapse, it comes over again. How stable is that microbiome in that population?
I think their microbiome is probably an absolute mess. What makes answering that question a little bit hard is because for a lot of these studies, at least the new ones that are looking at the Capsule FMT, they're excluding anyone who's immunocompromised or immunosuppressed. But because like the BMT population, the inflammatory bowel population, the transplant population are patients that are at such high risk for C. diff, they're definitely getting transplants. So it's not an absolute contraindication.
In like a first-time mild case, is it ever okay just to stop antibiotics altogether, or do you always have to treat with?
The literature says you can stop antibiotics. I've never just stopped antibiotics and not treated it, but the literature absolutely says that you can do that. And I think for someone who's not hospitalized and not sick, I guess not sick, but not critically ill, that would be a reasonable thing to try doing.
So just last month there was this high-profile article in the New England Journal and accompanying editorial about bezlotoxumab, this monoclonal antibody against toxin B. I just wondered if you had any comment on that paper, or whether that drug has a role in management of this ailment.
So I think they're looking at expanding the role, and I think there will be a role for monoclonal antibodies and probably a vaccine, in the next decade or so. I think the issue for us as pediatricians will be, when will we be allowed to use those kind of drugs?